I'm delighted to be here and to have the opportunity to contribute to this morning's set of presentations. We are going to talk about in this session engaging racial ethnic minorities in clinical trials research. And I'm thinking about this from both the therapeutic trials and the non-therapeutic behavioral trials. And you know that one of the metrics and goals at the Comprehensive Cancer Center includes making sure that we are adequately accruing racial ethnic minorities, underrepresented populations to clinical trials. And we could do better. There's been some progress, but overall, I think in the past couple of years, it's been relatively flat. So this is an area that we really need to continue to focus on. So of course, we want to make this, I'd like to hear from you, and that's why we had the clickers, but without that, maybe we can still have some of you respond to some of the questions. But the goal is so that we can talk about this in a way that is inclusive and accepting. You might hear things that you don't necessarily agree with. For me, that's fine. I think that's sort of part of the process. And I think all questions are valid, so anything is on the table that you would want to talk about or contribute to what we're talking about. So here's the first question, and as you can see, it does not recognize that your responders are on. Your responders should be on, but are they? Does it say welcome? Does it say vote? It says vote? Okay, so it is not asking you to vote, which is the problem. At this point, it should see everybody's transponders and then give you the option to vote when the question appears. So that is not happening, because that would mean that none of you have any improvements to make in the area of cultural diversity. I don't think everybody said that. So I don't think it worked. I think this is my data from our test run. Okay, so this is the first question. And just by show of hands, if you're you can always pass or participate with any of these questions, but how many of you would say that you have improvements to make in the area generally of cultural diversity? Okay. So most everyone, if not everyone. I think that's good in terms of a starting point and recognizing that we can all continue to work on this area as we continue to encounter people who have distinct cultural values and affiliations from us. Okay, so the second question, and the transponder is not working, so we're just not going to be able to use them. That's not fun, but we'll make it work. Second question, I believe that most of my colleagues could benefit from cultural diversity training. Oh, hands are up before I've even asked to raise them. Okay, so would anybody volunteer to tell me why you think your colleagues could benefit from this training, please?
So that we can say to these patients, we understand why you might be reticent, but a clinical trial is very similar to deciding whether you take your umbrella on a rainy day or not.
Okay,
That's a trial.
But my question specifically is why you think, and anyone else is free to respond, why do you think your colleagues need to have more training in this area? You must have observed something, or there might be some thought, or is it just you think everyone needs to have, so if I do, so do my colleagues?
I think everybody needs to be, we've gotten too politically correct in this country where we don't address things openly amongst each other. I think the patients don't feel respected or comfortable enough to say, I don't want to do this because. And I think we need to help foster an environment where they will understand that.
A lot of times you don't realize there's a lack of awareness of what we might not be knowing or what we might not know about, cultural diversity. It's just, I don't even think some of it's intentional. I think some of it's just programmed. And so I think we can always use a refresher and, because that's me too.
Okay, yeah. Very good. Thank you. Please.
Because I think we all have it in some fashion or form, the whole idea of this unconscious bias.
And I'd argue that we have conscious bias as well. That we do have the unconscious bias, but I think that if we just kind of focus on unconscious bias, that suggests that we don't really have conscious biases, and we do. We just do, if you're being honest about it. So, but I agree that's an important topic. So, okay, so cancer disparities is what we're going to talk a bit about, and we'll start with, and I think it's important to really get a definition of disparities. This was actually something that a colleague, a scientist, said to me. And I thought it was extremely interesting. As a matter of fact, I kind of didn't even respond right away. because I was just a little taken aback by the question. And actually, I came here recently from the University of Miami, and so this was a faculty member at the University of Miami, and I said, "Oh, I'm going to be going to Case Western. I'm really excited. We're starting a new office on cancer disparities research." And the person says, "Oh, that's just code for the study of African Americans, right?" And I literally was kind of surprised. So I was wondering what you thought about that, but we don't have the clicker, so we'll move on. So here's the definition, according to the National Cancer Institute, for what we mean by cancer disparities. So we are talking about adverse differences. These are population-level differences in new cases of cancer, all existing cases, cancer deaths, survivorship, and just the overall burden of cancer and related health conditions. And you find these differences in specific subpopulations of the United States that can be characterized in multiple ways. So the answer to the question is no, it's not code for the study of African American, because many populations, and then in general, people who are medically underserved, so that is they have limited access or no access to effective health care, have a greater burden of disease. And this is cancer, but then you find this, of course, across the spectrum of diseases. One key thing that I want to make sure I talk about is the difference between, or actually I should say that differently, the distinction between a disparity and a difference. People use these terms interchangeably, and sometimes what they're actually talking about is not a disparity, but a population difference. And how you know, or how you can think about is, am I talking about a health disparity or am I just talking about a population difference, is whether or not the differences that you are observing are unnecessary and unjust or unfair. So there's that undercurrent of unfairness if you're talking about a cancer disparity. So if you think about examples like, some sports teams might have more injuries than others. Well, that's a difference, but is that a health disparity? Men are more likely, or boys more likely to be colorblind compared to girls. That's a population difference, but is that a health disparity? That's not a health disparity. So that is an important point to think about, and some seminal research on this topic, and kind of trying to help people conceptualize what we actually mean when we say the word disparity, are the questions at the bottom. So if you ask, how would a person's health be different if they lived as a different race? What health factors would change, and are the changes rooted in some form of social inequity, which is also different from inequality, which people use interchangeably as well. But consistently and pervasively, cancer disparities exist. And here are just a few examples. So when you look at overall cancer incidence and deaths, so new cases of cancer, cancer death rates, we can see that overall African Americans bear a disproportionate burden from overall cancer incidence and death compared to all of the other racial and ethnic groups. If you look at breast cancer in particular, now this is changing. These data are a little bit outdated, but there are more recent data showing that the difference between white women and African American or black women, this gap is starting to close, where the incidence of breast cancer in African Americans women is actually starting to kind of match that of white women. But traditionally what we've found is that the difference is that white women are more likely to be diagnosed with breast cancer, and African American women significantly more likely compared to all other groups, dramatically more so, to die from it. Prostate cancer, you see the same trend, unfortunate trend, where African Americans suffer the greater burden of incidence and death. When you look at colorectal and lung cancer, you also see, just right across the board, the same disparity. So the key then is to say, well, we've identified these disparities, people have written about them, continue to identify them, we continue to talk about them, but what are we going to do about this? Like, what can we actually do? And I encourage each of you to think about, in your work, and really just in life in general, what can you do? What can your team do? Can you make suggestions to your team? Are you comfortable doing that? Hopefully you are. But certainly you can think about at your individual level, what can you do? Because if everyone had that approach, then we probably could see significant progress. Are there any thoughts before I give my suggestions of what can we do to actually see or lead to a reduction and ultimately an elimination in these racial ethnic disparities. Okay, so outreach is a very good example of what we can do, and I would say effective outreach, because the Cancer Center, both at Seidman and at Taussig, are engaged in outreach activities. Some more than the other. I think Cleveland Clinic has a bigger outreach program and team. But the key for me is always, how do we evaluate that? So if we go to health fairs, we give out lots of brochures. We have we bring the mammography bus to the neighborhoods. How do we know what our actual impact is? And I think that that's one thing that I'm focused on now being here, is helping the outreach teams develop metrics for actually evaluating our impact on the catchment area, to know if these efforts, which are not inexpensive and not time, and they are time intensive, to know if we're actually doing something in that area. Any other thoughts besides, other than outreach? Please.
I wonder if maybe instead of focusing on what could our solution be, wondering what are the barriers? So like what is actually stopping individuals from becoming engaged, instead of what do we need to do to engage them? So understanding that population first to figure out what's most effective.
So understanding barriers. We definitely do need to know what the barriers are. And I would argue that there is a large body of literature that's focused on the barriers. And I believe that in the work that you all are doing, it is important that you are active consumers of the literature all the time, not to leave that to the investigators or the PI, or that is part of what you're supposed to do, so that you have the answers to these questions and you can speak from the evidence base about solutions and about trying to understand what needs to happen, what is happening, and then what needs to happen. And certainly we do need to understand barriers. Now, cancer clinical trials, therapeutic and behavioral non-therapeutic trials are key research tool, as you know. Really, this is the way that we advance medical science and care. This is the way we direct resources. We understand what treatments work, what doesn't work, what's safe, what's not safe. And a very small proportion of cancer patients are treated in an NCI-sponsored clinical trial, very small. And then within that, the proportion of African Americans accounts for up to 10%. Most studies are in the range of 5%. Of clinical trial participants. This is problematic, given that this population experiences the disproportionate burden, health disparities, and death, and even incidence in many cases across multiple cancer types, many of which that are some that you probably are focused on here. So this is why this is important to focus on. And in this discussion, we'll be talking about disparities with regard to race, ethnicity, because of the need to further engage this population, because it's where the health disparities lie. We could talk about disparities more broadly and talk about other groups. And I think that's probably why my colleague thought that that's just code for the study of African Americans. And partly that's unfortunate that it's that way sometimes, because we, suffer the most from these conditions. And so the low representation of racial ethnic minorities in general, in any study, it's always a limitation, it's always a problem, because we want to make sure that our findings are generalizable at the population level. And when you are engaging in the kinds of research, unless it's a population-based study where you're getting a nationally representative sample, we always can say, even if our sample is diverse in multiple ways in terms of socioeconomic status and race, ethnicity, and gender or sex, we still have to be cognizant of the fact that our research may not extend beyond Cleveland in this case, but we want to have samples, of course, that are representative. But the lack of representation of ethnic racial minorities has implications for treatment, so that how do we know that certain interventions, certain therapies, certain drugs work the same for various groups? And perhaps the low representation facilitates this health disparity, the multiple health disparities, and that could be another contributor, in addition to sort of patient level barriers. That's the other thing I would like to encourage, is that we think about this more broadly and not just what's going on with the patients. Why aren't they participating? No, let's kind of look at the other side of it too, and look at multiple levels of that. If we're not engaging people in clinical trials, then therapies may not be as effective for them. And then of course there's systemic. I mean, we could talk about all of the different factors kind of upstream that lead to downstream disparities. One thing I also want to mention is that as we talk about groups, we always have to remember that there are individual differences within any population. There's always intra-group heterogeneity, which actually exceeds between group heterogeneity. So we have to understand that even if we're talking about Hispanics, African Americans, white, non-Hispanics, that within that group, there's still so much variation. And I say that because we have to be cautious about broad generalizations and stereotypes.
Can I say something on that?
Please.
Because one of the things I think is bit interesting is that, you know, the health disparities are, we have it, you have it by race right now. All whites are lumped together, all blacks are lumped together, but it would be good to see.
For me, that's sort of a generalization, actually, because I feel like among those groups, I would like to see this broken out by poverty level across the board. Do you know, in other words, how much of this is also a function of socioeconomic status, regardless of whether you're white or black, meaning when you access the system, how late do you come in because you don't have access to health care or because you have certain, you know, misconceptions about whatever. And that, I think, would be an important, that's something also important, you know, and just when we're talking about generalizations, that among all of the groups, there's a lot of, there might be other factors. I not to say anything about this is so important, and I totally support it, but I also think there's another
point. The socioeconomic status point is always something that comes up. So just by show of hands, how many of you believe that the, you know, and it's fine, like literally just trying to get a sense of where people are with thinking about this, because it always comes up. And I would say that among scientists and others who work in the field, that is usually the biggest explanation. Well, really, it's not about race, ethnicity, it's about income. And it's about insurance status. So if you hold those things constant, then these differences by race, ethnicity would go away. Some studies actually find that. How many people believe that that is really what we're talking about when we're talking about disparities? Or that's like the main root cause? Any? A few people believe that. Okay. How many people believe that that's not it? That it's more than that? Please. I would argue that it is certainly more than that, and I could have presented that data. I actually do have data, but you're right, most studies do not look at things with the interaction between socioeconomic status and race ethnicity. More research does need to do that, completely agreed. But of the research that has done that, we have found that even when you look by socioeconomic status, you still see the difference by race. So it's not just about, you know, and it's the whole notion of intersectionality, that people have multiple identities. So the experience of a white woman who is low income and a black woman who's low income, they're both low income, but their life experiences are still very different. Very different. It's not, so unfortunately, race adds that additional element of disadvantage. So you heard of people being referred to as like multiple minority statuses and things like that. And then if you were to add sexuality there, so if you have, you know, a Latino, gay, poor man, that experience is different from, you know, if you kind of jumble it up the other way. You have another man who's white, who's poor, who's straight. Like their life experiences are very different. So my assessment of the literature is that socioeconomic status is a major cause of cancer disparities and health disparities, broadly speaking, but that in addition to that, there's still this element that unfortunately has to do with race, irrespective of income and insurance level. Okay, so we were talking about barriers that somebody mentioned earlier, that we need to better understand the barriers. These are the barriers that the literature, this is not an exhaustive list, but these are, when you look across studies, these are many of the barriers that have been identified in terms of why people don't engage in clinical trials as they should. Because we know overall, irrespective of race, ethnicity, and socioeconomic status, proportion of people on trials is low. These are the reasons, general population. So I'm sure you're familiar with a good number of these reasons, but you know, people are emotionally, right from the beginning. I mean, you think about, you're getting this diagnosis and you're shocked, you're overwhelmed, and then someone comes and sits with you with a 25-page document that you should sign. It's like signing your life away, literally, for many people. So that is a major reason. But then you have other things. People are not aware of trials. So, and many say that if they were aware of trials, or if someone had mentioned it to them, that they probably would have participated. So that's a good thing. People are concerned about being seen as guinea pigs. They have misperceptions around the placebo group and whether or not they'd be assigned to a placebo. The exclusion criteria are often, you know, for trials where we're looking at efficacy and safety, we have to be very careful about the populations who are engaged. And so there are lots of criteria, which eliminates a substantial number of individuals. Many trials do exclude people who come in at the late stage. So when you think about ethnic racial minorities who tend to present late stage, this would be a factor that would exclude participation. Side effects are a concern. People are concerned about their continuity of care, generally speaking. They're also concerned with the efforts needed. IC means informed consent, and that, it kind of detracts from their hope about their situation. And there's a lot of effort to provide informed consent. They think things are very technical. Some people are just in denial. And things like transportation, childcare are general concerns at the population level. So let's look at some of the unique things that might be different when you look at racial ethnic minority populations. So this is specifically comparing kind of African Americans as a group in general. And some of the things that are key that you don't necessarily observe in terms of barriers in the general population have to do with the cultural beliefs or myths about specific diseases, fear and mistrust, which is different from just concern about, being a guinea pig, which is a concern, but there's a deeper level of the mistrust. And then the exclusion of late stage also applies here. Past experiences with healthcare is an important one. When you're not used to being treated well, and someone mentioned not respected, and then someone approaches you about something, even something that actually could benefit you, there is sort of the automatic wall that's there. And that if you're not talking to someone who's sensitive to that or understands that and specifically how to work with that, then that would be another reason that somebody would decline participation. I'd say knowledge of Tuskegee has been identified multiple times, although I'd argue that many people don't know the details of the Tuskegee study. They couldn't tell you exactly the details. They just know that people were denied treatment, or that something really bad happened, or that people were exploited, mistreated, conspiracies, all sorts of things. And then we also need to diversify the workforce, and that's one that we really can't ignore. People tend to respond to people who seem that they can relate to and who seem to be able to really understand their situation. One thing I hear, and this is kind of a strange aside in a way, but just as an example that you may all be familiar with, that in terms of the importance of having someone in front of you who kind of really understands where you're coming from is the way, so Donald Trump, right? You're familiar with him? So he says, I'm always struck by the way he says, the African American community. Anyone notice that the way he says it with this sort of distance. And I noticed that, unfortunately, even among my colleagues at times, and it's unintentional, but there's an intellectual way of speaking about African Americans that clearly is just intellectual with a distance. And then when you're sitting in front of someone, that can become apparent that there's a distance between you and them, and that you're not really connecting in the way that you should just as people. And I think it's unintentional in many cases, but it happens. Other populations who are also underrepresented, Native Americans, Asian Americans, Pacific Islanders, Hispanic. These are populations for which there's far less research on the barriers. We need to better understand the barriers as well in these communities. Because I'm sure, especially when you look at Hispanics, there are more reasons than that. But in my assessment of the literature, I'm really not finding much unique about this population, but there are a few studies who focus on it. So certainly cultural stigma, distrust is also there. Certain cultural beliefs in terms of cancer fatalism, the belief that my life's over, I'm gonna die anyway, so why do I need to do this or that? That's elevated among racial ethnic minorities and particularly Hispanics. And then there are design issues that do create barriers. And the design issues are not on the part of the patient. It's not a patient level factor. It is on the side of the investigative team. So when you think about stereotyping, there is stereotyping about hard to reach populations. I do not appreciate that term. Also stereotypes that certain populations are going to be non-compliant with treatment. Certainly there are language barriers. As an example, someone who so I have an elderly grandmother, Southern African American woman, and she, is experiencing various sorts of health conditions. And she says, I said, how are you feeling today, Grandma? She says, I'm not so great. My thighs are sticking. Who can tell me what she means? I can understand what she means. She says, oh, my thighs are sticking. I really don't feel good. I'll give you another clue. She has arthritis. That's her major chronic condition. She doesn't have cancer or anything like that, but that's a common thing. She says, my thighs are sticking. What does she mean? Somebody tell me. If you have a patient that comes in and you ask them and they say, my thighs are sticking, heck are they talking about? No one has any idea? A guess? Please. Good thought. No, that's not it though. Yeah. Yes. Her thighs are swollen. Her legs are very swollen, and so her thighs are together. So they're sticking together. No, her thighs. I apologize if I wasn't clear. Her thighs are sticking together. But those language barriers really can be major design issues. And we'll talk more about communication in a minute. Okay, I'm going to have to speed up. So physicians are also a barrier. It's not only a patient, physicians are the gatekeepers of trial information. This is how most people hear about their trials. Most racial ethnic minorities are not treated at comprehensive cancer centers. Most people are treated out in the community and they get referred in. So that's another kind of issue. But pervasive in the literature are the barriers created by the investigative team and by physicians. And I don't think that we focus on that enough. We're kind of thinking more about the patients and how to kind of change the patients. But we also need to change us and the way we kind of operate. People are in the community oncologists say that they are unaware of trials in their area, so they don't really know where to refer their patients. So we need to do a better job of outreach, not only in communities, but also to oncologists who work in the community and primary care physicians as well. Many people are unfamiliar with trials, especially those that are prevention trials, diagnostic trials, and screening trials. Many people don't know where to refer their patients. There's also the notion of things like the physician bottleneck, which really has to do with the staffing and the time and the workflow in the clinic, and just not having enough time to adequately do these things that can create a bottleneck. And then there are also misperceptions among physicians in the community, especially about placebo arms and that this won't be helpful for their patients. And then, of course, there are stereotypes. So my first recommendation is that we need to be more positive. We need to focus on what are the things that do encourage people to participate in trials. We kind of think about the barriers and why they don't, but let's think about of the people who do enroll, why do they enroll? And how can we channel that information to better serve those people who might be more reluctant? So some of the reasons that people enroll is because their doctor recommended it. People listen to their doctor. In general, they have lots of trust and respect for their doctor. Their doctor recommends something, they're more likely to try it. People also enroll because if you can instill a sense of hope in people, because one of the barriers is that the informed consent process kind of attenuates hope, but if we can instill hope, then perhaps more people would be more likely to enroll. And then, of course, there are those who participate because they just want to advance medicine, their sort of altruistic side. Other people just really want to fight, and they'll do whatever is necessary. They don't want to give up. Some people are aware or they appreciate the IRB protections that we have in place to make sure that we recognize them as people and that we're concerned about their safety. Some people will also enroll because of opportunity to get treatment that is not going to cost them additional money. They may actually earn additional money for participating. And then also people understand, when it's explained properly, that this really gives them access to cutting-edge treatment, access to top-notch, professionals and researchers, and that should be something that is an important motivator. So cultural considerations. We're going to go past this. We don't have time to really talk because that one's going to take us too long. Definition of culture. We talk about culture, but if you actually look at the definition of culture, you actually don't see race, ethnicity in there. When you think about what culture actually means in its broadest sense, it's a system, it's a dynamic system. It's got rules that are explicit and implicit. It's established by groups. It's about survival. They're shared by the group, but harbored differently between individuals. Communicated generationally, can be changed. Culture is slow to change. And the composition of culture, and this is, many times it is rooted within racial ethnic lines, also community, geographic locations. I mean, I'm not a Midwesterner. I've already understood a little bit about the culture here. It's different from the culture in Florida, and especially I'm coming from South Florida, which is a very different culture in general. So, I mean, culture really is very broad. So we do have to think about it in that way as well. Cultural competence, I'm sure you're all very familiar with this term. It's not my favorite term. It's really not. And the reason why is, the rationale is solid, right? The population is browning, which is important as health professionals, that you are, increasingly going to be interacting with people who are culturally different from yourself, and you have to understand how to work with them. I'm not crazy about the term, though, because it really kind of suggests something kind of academic, like something you can just learn and you can become competent in something, and then you're good to go. Versus understanding that it is a process, which I think everyone in here kind of recognized from the beginning, that it's something that you have to continue to work on, versus just saying, I got my certificate, culturally competent, move on. But these are some suggestions on how you can increase your level of cultural competence. And of course, things like awareness of your own cultural attitudes and really being, using your metacognitive skills and thinking about why you think the way you do or why you feel the way you do, and understanding that other people have different worldviews, that everything we think is within the context of our worldview, and that's the lens that filters everything we see. So someone else is going to be seeing it totally different from you. And I think the more you can understand that, and then take it a step further, and that is try to develop your interpersonal skills to really understand when someone says, my thighs are sticking, that you're really trying to figure out what they're talking about and how you might be able to help them. There's another view, though, that we have to keep in mind. Not everybody subscribes to this. Some people think it's just sort of the liberal agenda and that multiculturalism is not something that should be imposed. There are actually data showing, so more companies are engaging, corporations are engaging their staff in mandatory cultural diversity trainings. And what the data actually is showing is that these companies actually have more complaints about discriminatory behavior compared to companies whose engagement in cultural diversity for their staff is optional or not required. And part of that has to do, I think, with the notion of psychological reactance and lack of autonomy, where when people feel like something is kind of being pushed down their throat, it kind of creates a defensiveness, and they sort of close the door on it. So there are people who believe that there's not enough research to really support this, that the research that exists is not very rigorous, that it can lead to a false sense of effectiveness, kind of what I was talking about with regard to, okay, I've got my certificate, I'm gone, and that could lead people to actually practice outside of their scope of expertise. So sort of the newer term is cultural humility. I like this term a little bit better. It doesn't require that you kind of master, okay, what do African Americans think, what do Hispanics think, what do Asians think? It's not like that. It's kind of you understanding, and it's about more developing a partnership with individuals, and you just having a commitment to engaging in a lifelong process that begins with humility and how we check kind of the power imbalances that exist when you're communicating with people. Because the bottom line is we don't know anything, like you don't know every racial ethnic group, you just don't. So here are my questions. Can anyone answer all 4 of these questions? Hit it, all 4. Michael, you think you can answer all 4? Not just one. Who can tell me all 4? Nobody. Okay, classic example that these are not difficult questions actually, and they're very basic for each of these groups that we're talking about here. But it's something that you see, like you see women, for example, walking around all the time in Muslim attire. You don't know what that is. You don't know what that might mean to them, perhaps. Kwanzaa is something that is celebrated every year. Noche Buena. Somebody must know what that is, but you just don't know all 4. What is Noche Buena? Well, but what is it though? This is the clue right here. Oops, wait. Thanksgiving is a good guess. No, it's not there. It's actually a celebration of Christmas for many Hispanics who celebrate on Christmas Eve at midnight, and there's a feast and they exchange gifts on Christmas Eve versus Christmas. So they don't wake up Christmas Day and exchange gift. They've done it Noche Buena, which is on Christmas Eve, just as an example. So this is about cultural humility, and it's just the point that we don't know a lot, and these are things that are in our patients' lives and things that are affecting them that we don't have the answers to. We don't really just know. We don't really think about it. So it's important that we have a knowledge of how people's culture might influence them in terms of how they obtain healthcare, whether they're comfortable asking you questions or not. Certain groups may feel it's disrespectful to ask you certain questions. They might feel embarrassed even. They even may have cultural differences that help us understand the acceptance of certain medical advice. Okay, raise your hand if your answer to this is yes. A few people. A good number. Okay. How about no? Who's just tired this time? A couple people tired. Yeah, it is exhausting. I will give you that. All right. How about your answer to this? How many people could say yes, that you have observed racial discrimination, even subtly, and remain silent? A good number of people. Okay, why are you silent? I don't have a lot of time, but I just need a couple answers. Go ahead. That's a good point. For those of you who may not have heard her, she was saying it's difficult when there's a power imbalance in the relationship. And so if she has observed an investigator, her PI, her supervisor say something that she's, it's uncomfortable. You don't really know how to handle that. But most of you have observed something and you view, and it ranges from not good to really good. I'd say proficiency is aspirational. Most people are not culturally proficient, but those who are would never be silent, even in the face of something that is subtle, or even in the face of there's a power imbalance. They'd figure out how to bring it up or talk about it or intervene in some way. I will mention just that the cultural blindness is where some of you are, based on your response to the question about that you don't see color when you're in front of someone. This is called cultural blindness. This is kind of, I treat everyone the same. And the problem with this, it's well-intentioned, but it's relatively naive. We all see, you can't miss this. You can't miss it. When you're talking to someone, you know, if I ask you, oh, well, you met someone, were they old, young? You know the answer to that. You see who you're talking to. You're not absent kind of taking in the person that you're talking to. But I think what people mean by that is, I'm not, racist, I don't see color, like it's not. And then many people, especially people in the white, majority population, were taught as children not to talk about race or not to see those kinds of things. From a multiculturalism perspective, though, people who are diverse, people of color, don't want you to ignore, want you to just appreciate and respect and see a value there, but not feel this desire to say, I don't see it, because you do see it. And so that's considered culturally blind, but I think it is coming from a good place. And then as you move from there, you become pre-competent, which means that you have started to really explore cultural issues. You're not trying to kind of not see it. You're willing to see it, and you're trying to but you have limited knowledge and resources, but you're interested in gaining that knowledge. Cultural competence, the actual definition, is that you do recognize that there are differences. You seek advice from people who are in those groups. You actually interact with people from those groups outside of a work setting. And you hiring, you appreciate the value of a diverse staff. You're committed to enhancing services for underrepresented or otherwise marginalized groups. Proficiency, as I mentioned, is kind of that aspirational level of that you're really trying to improve services based on cultural needs. You're an advocate, you're an activist, you would not sit quietly. So my third recommendation is that you engage in ongoing development of both your cultural competence and your cultural humility. And a couple of just implications for you is, this can be an emotional journey. And I think that's good. If you feel uncomfortable, that actually generally means that there's some progress happening, or there's something going on within you that probably could be positive if you don't allow it to make you feel defensive, or that you can't talk about it. Or you just kind of don't want to have a disagreement with someone. We're really going to have to go through a process to make progress here. But many people have negative emotions, and I just encourage you to explore yourself. Everyone is a cultural being. Everyone has, everyone is involved in terms of their cultural identity in multiple groups. So you want to kind of think of yourself in that way. And then in terms of informed consent, I do want to mention that many people have challenges here, because just in healthcare in general, many people don't understand what's being told to them in a healthcare situation. Partly because you're going in, you're fast, you don't have a lot of time, you're explaining, people are sitting quietly and nicely. You have any questions? No? Okay, you're moving on. They understood it. Not quite, especially when it is compounded by emotional vulnerability, where you really can't take in all that you're hearing because you're just in an emotional state psychologically that just doesn't allow that. And then, people feel shameful about their inability to understand things. So health literacy is important in terms of engaging populations in clinical research. Health literacy really is someone's capacity to understand health information in a way that allows them to use it to inform their healthcare and their decision making. So it affects people's ability to navigate this very complex system we call healthcare, to share their health history with their physician and not just say that their thighs were sticking. Here's another example. My grandma feels like something's pinching me in the chest. How are you doing, Grandma? Something's pinching me in the chest. What's that symptom? I'm sorry, I think I heard it. Chest pain is what she's trying to say, that she has chest pain. It could be heartburn because it's hard to get the answer from her. But I think she's referring to that she's having chest pain. But health literacy is something that is always a concern. Most people don't remember everything, and then of what they do remember, there are lots of inaccuracies if you were to go back to do that. So you want to address health literacy as a recommendation, but by using very plain language. Documents that you're giving people should be written no more than at the 6th grade reading level, which is difficult. That basically means 2-syllable words for the most part, 1 to 2-syllable words. You want to have very limited or no research jargon. The word usage, there are research studies showing that when people are using the terms interchangeably, clinical trial, medical research, research study, that people have different preferences about these words, but you should choose one and kind of use it consistently and make sure they know what you mean. Getting to the point, and the teach back method is important. So, and these are examples of plain language. So basically making things from 2 syllables, from 3 syllables and higher down to 1 or 2 syllables, which can make, negative just becomes bad. Or it could be good depending on the test result. But we would say, instead of tolerate, we'd say handle. Instead of saying we're going to give this to you orally, you're going to take this, you would say by mouth. Instead of modify, change, those sorts of things. Instead of procedure, we say process. So we really want to use very, very plain language, which is tough if that's not the way you generally speak, but the person you're talking to may not fully understand it. So the teach back method should become standard of care in your work with patients, I would argue. And the teach back method is a way for you to ensure that people understand you, but doing so in a way that doesn't shame people. And it's an indication of really how you're doing as a health professional and explaining things to people, and it's not a test of how your patients are doing. So here are the elements for using teach back. So of course you want to come across as empathetic and caring. Plain language is important. Making eye contact. The key part, though, is having them explain back to you what you've said using their own words. That's your way to know if they really took in what you've said. But you're asking questions in a way that's open-ended and non-shaming. So you don't want to say, that can be tricky. So you have to make sure you practice how to ask them to repeat it to you so it doesn't seem like you're talking to a 5-year-old. And then, of course, using reader-friendly print materials. I'd say 1-pagers, very simple language to kind of understand what the trial, for example, is saying. Here are a few examples of how you could use the teach back method, the way you could word things for people. Asking them what they're going to go home and tell their husband about the changes they've made or about this trial, because if they're not signing the consent form right then and they have time to think about it and they want to go talk to someone about it, you could ask them how they would explain this to someone else as a way to understand, are they really understanding it? And then saying, I've said a lot today. In your own words, can you review with me what we've talked about, just so I can make sure, you have it. Those kinds of things should become standard practice, I think, for you. And then in terms of recruitment strategies, these are sort of overall, we need to do better on our clinical trial enrollment across the board. So here are some suggestions. Outreach is definitely a part of it in terms of number 3, I would say. But then also things that, asking people if they want to take a tour of the study area, that's number 6. I think number 9 is important for the referral sources. If they're coming from the community, if you give them feedback about their referrals and how many people that have come in, and that kind of feedback can positively reinforce people. And then in terms of for increasing engagement among underrepresented groups, key things are, all of these are really key, but I think clarifying the agenda behind the research might help to mitigate some of the concerns about the purpose of the research or what's going to happen and really what your agenda is here. Speaking the language of the community is important. My aunt says, I have cold in my body. What does she mean? Nope, not chills. She says, I have cold in my body. That's a good thought, but it's not chills. I'm sorry? No, not that she's stiff. Yeah, phlegm, absolutely. She's got phlegm in her body. She says cold in her body. So you have to learn how to speak the language of the community. And if you're working with communities, I think you need to kind of understand what people are talking about. Otherwise, they're going to create barriers. And then, of course, using flyers and information brochures and all of those things. I think if you have a 25-page consent form, if you could distill that down into 1 page, using very plain language, hitting the most important messages so that people have that in addition to the consent form to review and to help them understand, that has been an effective method. And then, this is the last thing, is that, really, this is my conceptual model for how to engage people in clinical trials. And one thing I focus on a lot in my own research is culturally specific interventions. And that that is that you kind of consider the cultural values, also the cultural assets. I think coming from a positive perspective is something we need to think about. But all of these factors you think about when you're working with the populations that you are most likely to encounter. And you kind of add those into the standard intervention components, the things that you kind of do for everyone, but you think about culturally what might also be important. Time orientation is an interesting one too. For example, African Americans are very present and past oriented and tend to be less future oriented. Well, that has implications for hope, for fatalism, for engagement in trials. So I think understanding that, and certainly language patterns. When I talk about language barriers, as you can see, it's not just do you speak Spanish, do you speak Chinese? It's also about just the use of the English language. But that these things together, and then you have individual differences that can certainly impact their decision to participate in a clinical trial. And then you have other modifying factors such as socioeconomic status and insurance that will directly predict whether or not people decide to participate in trials. So it becomes complicated, but the bottom line is enrollment should be about social justice. Reducing disparities in terms of enrollment for ethnic, racial, minority populations. It's about providing equal access opportunities, doing whatever you can to be inclusive, recommend things to your teams that you work with. I think but it should become a part of your dialogue on a regular basis and kind of keep it at the forefront of your mind so that we can really work to remove the barriers, individual level and systemic barriers. Okay. That was your last question. Yes? Okay, good. You don't have a clicker, so I'm just going to go with that. Okay, thank you very much.